present the CV of Seta Lakshmi Madam.
Aesthetic gynecologist and aesthetic physician from Hyderabad. So I'm handovering the mic to Dr. Seta Lakshmi.
Cosmetology practice. She is very well known to the Hyderabadi people. Very film actors and everybody used to visit her for her consultation, for treatment and everything. And her husband is a plastic surgeon. His name is Dr. Sri Nagesh. He does a lot of plastic surgery work. So let us have a topic of Mrs. Seta Lakshmi. Welcome.
Thank you, ma'am. This is something called a refreshing moment for all of you all after listening to so many surgical procedures. This is cosmetic gynecology. Why its existence has come into gynecology and cosmetology as a part, because many women today are looking for something that will better their lives. The quality of life is much more important than leading a very long life with a lifespan. So there comes the problems of the later lives as you enter your menopause or later lives. That is called stress incontinence. As you all have know that, and you have seen many patients with this condition till now. I know that. During my PG days also we have seen that. But that focus has changed from a surgical to minimally surgical interventions in this part of the disease. Stress incontinence is not a disease, of course. It's a condition characterized by involuntary leakage of urine during activities that increase the abdominal pressure, such as coughing, laughing, and sneezing. So this is primarily caused by weak pelvic floor muscles. That is what we were thinking. But of late we have also seen that hormonal changes caused by estrogen lack, either during menopause or hysterectomies, do influence the pelvic muscles, pelvic endometrium, and all the organs in the pelvic region. Added to this, we are again burdened with the cause called obesity, and this increases the intra-abdominal pressure, therefore pressure on the bladder, and increases the chances of urinary incontinence. So certain surgical procedures are also known to cause this thing. And also we have seen very young women with this stress incontinence. Probably they are also having a genetic predisposition to the stress incontinence, and often appears in the recent delivery period. That's the postpartum period. This is less distressing, and we assure that this will decrease as the postpartum period is gone. Now, the symptoms are usually the leakage of urine during physical activities or exertion, definitely while coughing, sneezing, and these activities. And usually you can differentiate this from an urge incontinence, because it is not associated with the condition with urge or sudden increase in the abdominal pressure, only causes this symptom. So there is a very short phase from the time in a menopausal women when the stress urinary incontinence becomes the urge incontinence. So for early detection is very important to give a quality life. So associated with other symptoms of GSM, as you know, we are all treating for the genitourinary syndrome of menopause these days. So it is very commonly associated with them. Therefore, the women may be confused with the symptoms of genitourinary syndrome for the stress incontinence also. Therefore, careful counseling is the first step in this. General population, it ranges from 10 to 30% is incidence, but as the prevalence increases as the age increases. Young women may experience only, I told you, some genetic predispositions, it is around 5 to 10%, but middle-aged women, it can lead up to 50% in the older women. So men are not very much in this, except for the prostate surgeries. Gender, as we know, it's a women basic disease. Ethnicity is more prevalent in more Caucasians rather than the African and Hispanic. Probably the pelvic musculature is much more stronger, or the hormonal influence is better in these groups. Therefore, obesity is a risk factor, as I told you. Reproductive history, a large number of vaginal deliveries definitely predispose the pelvic musculature, weakens the structures, and this may cause the stress incontinence. There are other comorbid conditions like diabetes and neurological disorders which are associated with chronic cough, and therefore these also can cause stress incontinence. Of course, socioeconomic factors and access to the good health care can diagnose these features faster. So in the diagnosis, the medical history clinches the diagnosis, as proper history has to be taken from the onset, the time of onset, the type of activities that produce this kind of a stress incontinence. Of course, a pelvic examination to rule out other infections, the proper the cervix and all should be examined as a preliminary thing. A pap smear is very much an essential, at least 6 weeks before you plan something for treatment for the urinary stress incontinence. Especially women has to be asked about their urinary diary, that is their habits of urination, what causes, what is the liquids that they take throughout the day, is there an increase in the intake, and followed by that there is a urinary incontinence. Therefore, this tracking of their urinary diary will help us to know the onset of the stress incontinence. Urodynamic testing is usually not done in a plain stress incontinence, but in older women it may be needed because there could be some sphincter problems or irregular neurologically controlled mediated stress incontinences. So it may be needed at some, but it's a relatively invasive procedure, so we will put it in the last. Other lab investigation, definitely the pH of the urine. pH of urine more than 5 is always indicating some infection or some other diseases. Therefore, from pH to urinary normal testing and cultures, we have to be thorough with those things. Then usually we don't jump that, yes, I'm a cosmetic gynecologist, I have this thing at my place, so let me experiment. We don't jump to these conclusions. We have to weigh the procedure, the benefits for the patient and the lifestyle, and then give them options. Conservative options always play a major role, but the conservative options have to shift from a pad. I stress again, pad-free life is better than having a pad and leading a great life. Therefore, pelvic floor exercises have to be taught, that is Kegel exercises. Everywhere they are advertised, but the proper Kegel physiotherapist has to be there to introduce them to the client, and they have to be taught in a specific way, and they have to be followed up. Only then they will be useful. Then lifestyle modification, maybe weight loss will always help, control of diabetes will help. Bladder training, particularly older women have to be educated that decrease of liquids in the later part of the evening has to be followed. So then their other activities will be much less stressful. Medical interventions usually are the first and foremost are topical estrogen. Many gynecologists were also scared to introduce topical estrogen, but things have changed, and this has formed the first line of management in this kind of a genitourinary syndrome or the stress incontinence. There is a tremendous relief for the client, and she can pull on for some more days before she comes for a particular kind of a treatment. Antidepressants, especially because this is a stressful condition. Somebody who is active in her life having a stress incontinence will limit her activities, be it an office going woman, be it a doctor, be it anybody, or be it a housewife. Therefore, antidepressants also play a very good role in controlling these symptoms. Pessaries, I have not seen many, and they are also associated with many cumbersome things. Therefore, pessaries are not very regularly useful, but of late investigations are, research is going on, and an FDA approved pessary, it's actually an battery-driven device that's going to come into the market, which may be useful for certain women. Surgical options are again sling procedures and Birch colposuctions. You have seen very complicated procedures have been shown. So these are also an option, but have to be weighed accordingly. The emerging treatments are non-ablative radiofrequency therapies. Technology is increasing everywhere. We are adopting technology in a very better way. So why not in this field of gynecology? There are also biological therapies introducing cells from your own fat stem cells into the space between the urethra and the anterior vaginal wall, where it is supposed to increase the collagenation and improve the bladder support. So strengthening of the muscles of the pelvic organs is the first and the foremost thing. That is Kegel's exercises, I told you. Certain exercises like hip flips and bridge exercises have also been useful, but it has to be emphasized that it's a continuous process. So to strengthen the pelvic muscles, also nowadays we have chairs called emcellas and other instruments which can be used at home. So this is one of the vaginal RF machine. I'm not endorsing, there are many in the market, I'm not endorsing any of them. They are monopolar RFs, there are bipolar RFs and different types. They mainly go with the non-ablative RF therapy. RF, you know, have been widely used in the surgery and outside the surgery for many years now. The same technology has been introduced in the form of a non-ablative technology. So as you see, non-ablative technology is very easy to do. It heats the tissues along the vaginal canal, and you know the anterior vaginal canal is very close to the urethra, and that is where it helps to percolate the heat energy and then cause neocollagenation. This is called so this is the procedure, how it's done. It's a very brief one. So it is like introducing a small sound and rotating it in the anterior vaginal wall and in both the halves and the lateral vaginal walls and the posterior vaginal walls for the complete rejuvenation. But for the urinary incontinence, if the anterior vaginal wall is heated up to 42 degrees, which is controlled on the machine, therefore it is very safe. For 5 to 6 minutes, you are going to get the advantage of the mucosal edema, then followed by neocollagenation. How this works? It works on the principle of deep penetration on the mucosa, that is it goes up to 4 millimeters, and whereas lasers, they go only up to 0.5 to 0.5 millimeters. And this is a very safe outpatient procedure, no anesthesia is required and no special safety gear is required. Therefore, the patient can walk in for the procedure provided all the other investigations are in place and get the treatment and walk away. So that's the mechanism. It reaches the lamina propria, that is very important, where the muscularis is also acting, and therefore neocollagenation occurs. The heat does not stay on the epithelium, it immediately is transferred to the other layers of the tissue. Therefore, a temporary feeling of heat is experienced by the patient, which is not very uncomfortable, and it immediately disappears within minutes. Within 24 hours, the patient can adopt a normal lifestyle as usual. So there are other uses of radiofrequency. It's a versatile technique. It has vaginal laxity. It controls the dryness of the menopause. It controls the urinary incontinence, as I was mentioning. Appearance of the labia can also be manipulated with the with the radiofrequency, which has a special probe. There is also during discomfort, that is dyspareunia during sex and sexual dissatisfaction are improved. Therefore, it's a versatile tool. So that's the benefits I've already put. The most important benefit, it is causing a neocollagenation, support to the bladder, as we thought that only pelvic musculature, but now the recent advances have shown that the neocollagenation around the urethral bladder neck is very, very important to support it and causes sphincter changes. So side effects are usually a swelling or redness or itching, which is very, very minimal compared to any other procedure. Risk of burns is very rare and only happens if there is it is exposed for a longer time than expected. Now the recent machines are all well controlled and there is absolutely no side effects with these. Infection, of course, is very rare. So, but the only limitation are the patient selection. Most of the people come very late when it becomes a missed incontinence. It can be associated with cystoceles and rectoceles. Even in these cases, when there is a mild cystocele or a rectocele, still the vaginal RF can be done, and you can also see certain improvements in the cystocele. It is very hard to believe, but technology is such that it is causing good changes and improving the quality of life majorly. The mechanism of action is, I told you, it increases the elasticity. Not only contracts the epithelium, collagen, and then increases the elasticity in the tissues. Therefore, vaginal whole 360 degrees of the vagina can be treated to cause a tightening also. So the combination therapies have to be used for some time for both the benefit of the client and benefit of the doctor. Efficacy is very good. It may range from 100% to 0, depending on the client's perception and the condition that we have selected. Since the results do not last for a very long time, repeated treatments are necessary in 1 month interval, and once you finish 3 treatments, you can see a very prolonged good results. So it's not the first line of management. Nevertheless, it is a very, very useful tool in armamentarium of a cosmetic gynecologist. It is very promising, and there are a lot of advances that are going in. One thing I was telling is diagnosis is very, very important, first of all, and the counseling is very, very important. It will not be like a general gynecology. Cosmetic gynecology takes time. 1 hour for a client has to be spared. So the ongoing research and trials will give us a lot of combination techniques in future. Thank you. So I thank one and all for giving me this opportunity, especially the organizers and Radha Lakshmi, Nirupama Madam and the Foxy of Kurnool. Thank you.